Hello and welcome to Pain in the Podcast, your place to find out everything you've ever wanted to know about pain. My name's Dr. Joseph Parsons, and I'm joined by the phenomenal Don Wigesoria and Dr. Joshua Craw, and a very special guest today to talk about sickle cell. Welcome in. Hello and welcome to another episode of Pain in the Podcast, where today we're going to be joined by a very special guest who you'll hear from shortly. But to start with, we are going to talk about our facts and learnings for ourselves. So let's start this week with you, Josh.
Yeah, absolutely. Well, hello everybody, welcome to this episode. My fact for the week is my favourite tree is the cherry blossom tree.
Could not agree more.
Gorgeous, especially when it's nice and pink.
I grew up in Sheffield. There's a road in Sheffield called Carternole Road that has cherry trees the whole way up. And so if you go there, like at the end of kind of cherry blossom season, you'll come down and it's like a constant snowstorm of cherry blossom. It is stunning.
And when the sun's shining, it's beautiful.
Outside York City train station, it's all lined with cherry trees.
Is it?
Yeah, gorgeous.
If you really want some wholesome, like, to get over the seasonal affective disorder, that depression you feel over winter, I think the cherry tree blossom is just, it's a great way to kick the sadness.
Welcome to spring.
I also saw a lot of, I couldn't tell if they were cherry blossom trees or not, but on the way from the airport when I visited Castellón de la Plana in Spain, there was just so many pink trees all over the place, and I wasn't expecting that from Spain. Very pretty.
I think brown when I think Spain.
Exactly.
I think like lush vegetation that's been burned to a crisp.
But it was beautiful.
Thinking of nice hot climates, a fact about me is that I have recently learned how to judge the perfect watermelon.
Oh, tell me more.
So the little, the little bits that it grows on, the little thing that you pull it off the stem, so the little nibs at either end, the little like brown bit at the end. Apparently, the person who did the video referred to it as a bum hole, and they said that the tighter the bum hole, the sweeter the watermelon. You should also look for a darker green rather than a lighter green, and then you want to have yellow patches on it, so some small yellow patches, and on those yellow patches you want those brown, like slightly hard bits, like the browny beigey.
Oh, the cracky lesion kind of things.
Yeah, so they're called bee scratches. So apparently that's where bees have been excited about being around that particular thing, so it's really sweet. So yeah, tight bum hole, dark green,
Horny
patches
bees.
of yellow, horny bees, and then you get the perfect watermelon. And so far, 100% success rate.
Hot damn, that's definitely a watermelon.
It is, yeah. It's never not been a watermelon. Anyway, Don, what's a fact about you?
A fact about me is I really like snake plants. Really boring, but snake plants. They're great for air purification properties, or whatever the people say that
What is a snake
it means. Snake plants are like the really tall succulent-like leaves. They have like stripes on the side. They're kind of, is it variegated? They can be. They come in variegated types, I think. And it's just, a nice, easy plant to grow. And also they look cool. They're like little swords sticking out the soil.
Apparently, very low maintenance.
Very low maintenance, yeah.
We like low maintenance.
And they can be propagated really well.
And drought tolerant as well, so if you get to put water in them, they're absolutely fine.
Oh, yeah, I haven't watered mine in like 3 weeks.
In about 3 years.
Because I just forgot and went on holiday. But yeah.
Nice. Right, learnings. Yeah. Josh, what have you learned about yourself this week?
Well, recently for my New Year's resolution, we're now filming this sometime at the end of February. I've gone for a healthier diet. I'm eating a lot more fruit and veg, like at least 6 or 7 portions of fruit and veg a day, on average. And, well, I don't think I need to say what the results of this might be, because my 2 co-hosts...
We've
We've
been subjected to both the smells and the sounds of this new diet that Josh is having.
And the poor dog that I'm dog sitting for as well.
Well, Don has been asking Josh to go outside in the same way that he's been asking the dog to go outside. So
it's toxic.
It is toxic. But you know what? It's working. You're feeling better. It's helping you lose weight. Yeah, it's working really well.
Yeah.
In all ways except the stink. It's going great.
Yeah. Absolutely. Joe, what's your learning this week?
My learning is that swearing really does help to ease pain. And I found this out because I was in an occasion where I couldn't swear. When you're in hospital, patients will often have bed rails, so they'll have rails at the side of the bed to prevent them falling out, especially if they're kind of maybe for various reasons. But like on a bunk bed, it accepts that they can come up and down. And so you pull out a little sort of toggle, and that allows the rails to be lowered down. And so I had a patient who was very eager to get out of bed to do a therapy session, and I started lowering the edge of the bed down, and they started swinging their legs out. So I then dropped the edge of the bed rail because I didn't want them to get trapped in it, and I dropped it right onto my thumb, and I had to pretend that it didn't hurt. And
was your thumb trapped underneath on top of something else? No.
Thankfully, it trapped it, and then I managed to get it out. So it was trapped in the bed rails, but with some of their weight pushing down on the bed rails. And one of the staff that I was working with during that particular session was like, "Trapped your finger real bad, didn't you?" And I was like,
Did they see the face?
Oh yeah, no, I mean the patient didn't, because the patient was like over them. They were like, "Whoa, right. Fucking go, whoa!" Okay. Which was not great. And I realised that not being able to swear, and my natural response would have been to have gone, "Fuck!" But I couldn't do that, so it felt a lot more painful when I didn't have that kind of outlet. So there you go. Anyway, Don, what have you learned about yourself this week?
I've learned that I really like my new Loop earplugs, and I have been sucked into it by Instagram. Thank you very much.
What are Loop earplugs?
Loop earplugs are reusable earplugs.
Tiny little, not foam, silicone-y type loops.
It depends which ones you buy.
Oh, those are the orangey ones that are in your room in that box?
Yeah.
Yeah, they're really good.
They are... Thank you, Josh. I saw yours on the side.
With all the wax.
I've heard really good reviews.
His ones have got wax on
they're
the
brand,
ends
They're
of
brand
them.
new. I literally brought them fresh out the box.
Yeah, I don't know if that's a good thing.
Well, you already had wax
That
on.
you've already,
After
they're
one
already
night.
covered in wax.
Before the night would have been worse. Fresh out the box.
Fresh out the box, it's the wax.
Second hand. They were returned by a previous customer.
But yeah, I really like them. I've been using them on flights. Really good. When we were in Spain, I'm talking about Spain a lot, but when we were in Spain, it was super, super windy. Really, really windy. And it was still quite hot. So we had the windows open and the fan going, blah, blah, blah. I don't think we had air conditioning. We did, but only in the living room. Anyway, it was so windy that throughout the night, everything was rattling. Like the front door was rattling, our neighbour's front door was rattling, the window...
You were rattling.
Our beds were rattling. It was all so really, really noisy. But yeah, earplugs, they worked. And also, the earplugs are really good because they really do help me focus. Like they always say, like, you know, you use earplugs
Blocking
to
out
focus.
background
But
noise.
because I always did that with my AirPods. I just stuck them in and then turned the noise cancellation on. But yeah, the Loop earplugs are comfortable and they work really well. So yeah, they are expensive. Bring the price down, please.
How much were they?
I don't know.
Too much.
I can't remember because I bought them when I was in Australia.
How many decibels do they block out?
I want to say like close to 20.
Well, that would have almost helped the listeners of this podcast who just heard our air fryer going off in the background. They would have nearly been able to cancel that out had they had Loop earplugs in.
But if you are hearing the air fryer in the background, that's a little sneak peek into some of our bonus content.
Okay, so that is all of our facts and learnings. So let us move on to the main bulk of the episode. So we're very lucky to be joined today for our episode about sickle cell disease by Dr. Lewis Thomas, who really couldn't be a more perfect guest in that he has medical training, and so he sort of understands all the science behind it, lives with sickle cell disease himself, and has set up the Sickleverse, which I'm sure Lewis can tell us far more about. But do you want to do sort of a brief introduction to yourself, Lewis, and about what you've been doing within sickle cell disease?
Yeah, sure. So I am a GP, trained as a GP, and I live with sickle cell. So sickle cell has been part of the reason why I've left GP now, because of having to struggle against, I guess, living with a chronic condition like sickle cell and the stress of being a GP. So part of what I've done is use the knowledge and the medical training, as well as the lived experience of having sickle cell, to help other patients to really understand more about sickle cell and how to advocate for themselves. One of the major problems that I'm tackling is that sickle cell is so poorly understood within healthcare professionals, and that leaves patients to do a lot of the work to, advocate for themselves and get adequate care. So I'm really trying to support people with that, and what I've created now is a community called the Sickleverse, which is basically an online education community to help patients understand sickle cell better so they can advocate for themselves.
Amazing.
Sounds fantastic, yeah.
And I mean, I think I came across your work originally through social media, because you have a lot of sort of educational content on social media. And one of the posts you did was talking about common misconceptions in sickle cell disease. And I thought that might be a nice place, before we dive into sort of what it is and how it works and how it's treated and sort of how people have been mistreated in the past. Maybe we can talk about some of those common misconceptions to begin with.
Yeah, sure. Okay. There was one that came to my mind off the top of my head whilst you were speaking. You can ask if there was any specific ones you wanted me to mention, but one of the issues with sickle cell disease is that people tend to want to put it into like a box and think that everyone who has it is exactly the same. And this results in there just being this this barrier. So sickle cell is different in each individual who has it. A lot of people will get pain, regularly and frequently and have to go to hospital all the time. But some people, it will just be every now and again. But the issue is that everyone should have the opportunity to be treated as an individual, as opposed to, lots of assumptions being made about, what you're going to be able to do as someone living with sickle cell. And I think that also creates a lot of stigma as well. So one of the main, preconceptions is that if you have sickle cell, it's, a disease that can be, what's the word? If you have sickle cell, it can be sort of contagious and people can catch it. So that's something that causes a lot of stigma around the word disease. The other is that people don't really understand that it's genetic and how it's inherited. So a lot of the times people with sickle cell will be in hospital with healthcare professionals that aren't really aware of sickle cell. And they'll get asked the same questions, how long have you had sickle cell? And they'll say, it's genetic, I was born with it. But it's just one of those annoying things that immediately tells you this person doesn't understand sickle cell, and therefore I'm going to suffer because of it. Because that's what it is. You go to hospital the majority of the time as a sickle cell patient because you're in pain, and having to navigate around so many barriers to getting the actual pain relief, to get out of pain, is something that causes a lot of unnecessary suffering.
I wanted maybe to touch on what you've just said there about the barriers that people experience on receiving appropriate sort of pain relief. Obviously, there's the element of the lack of understanding from the clinicians, but what else do you feel are some of the barriers for people not getting treated appropriately during a crisis?
I think there's obviously the racial bias that is, unconscious among healthcare professionals. Because sickle cell is such a severely painful condition, it does require treatment with adequate opioid analgesia. So there's obviously a lot of stigma around opioids because of the opioid epidemic. We have a lot of doctors and clinicians that are now trying to be more restrictive with their use of opioids. And this is where sickle cell patients often, end up suffering because we have a genuinely painful condition. However, it doesn't. There aren't any like physical signs of pain, and I guess you'll probably understand this better than most people, but like when you are used to pain, you're not always going to be sort of screaming and crying and shouting, because it gets to a point where that isn't helpful. It's just causing more stress. So it can put you in a situation where you're sort of having to prove that you're in pain. Otherwise, staff won't take you seriously. They won't give you the medication because they're hesitant about it. On the other hand, sometimes if you're doing too much, if you're being too loud, you're deemed aggressive, and you're put into the role of a drug seeker. So it can be very difficult to sort of, it's very difficult when you're having to think, how am I going to play this? The fate of your sort of, personal comfort is in the hands of people who don't understand pain, who don't understand what sickle cell is, and who are clearly being influenced by negative racial stereotypes. So that can be really hard, and I think it's something that every patient with sickle cell has to go through as they transition from pediatric to adult care. And this is an area where we're trying to improve that sort of transition as well, because it's very hard for young 18-year-olds to go from the sort of care of the pediatric children's ward where everything is nice and they're being treated with kindness and compassion, to turning up to adult A&E and just being looked at as a drug seeker, and no one really understanding what sickle cell is or why they are in so much pain, and that nothing really prepares you for that. So yeah, I can't remember the question now, but that is like a key experience of sickle cell disease.
Yeah, absolutely, Lewis. I think you've hit the nail on the head there. I don't have sickle cell, but I know somewhat about sickle cell. As I said, I'm an emergency medicine doctor, and our Royal College of Emergency Medicine says that everybody that comes in with severe pain should receive IV opioids as first line rather than going up that World Health Organization ladders. If you're in a sickle cell crisis, you're in extreme pain, you've got a vaso-occlusive crisis, giving paracetamol and waiting an hour for no real significant effect it's almost torture, isn't it, I suppose?
Yeah, and I still hear from patients that they have to go through that. And again, it's a case of having to learn from each painful episode what should be happening and what shouldn't be happening, and figure out what the right way to approach those hospital situations is. The annoying thing is there are guidelines now, like very clear guidelines, and patients often have care plans, but for some reason the clinicians in the emergency department don't use them.
Yeah, that's one thing I was going to bring up, those care plans, because where I trained at St George's in London, which has a high proportion of service users that do have sickle cell. Patients coming and they do have their notes with them. They have, this is the medications I need when I'm in crisis. Please, give me.
Follow this plan. Yeah. This has been discussed with medical professionals. This is what I need.
But it's difficult. It's difficult. And as you mentioned, with racial sort of stereotypes, we know that non-white patients receive less analgesia than white patients do.
And are more likely to receive sedatives, which is just absolutely terrifying that this is still an issue that we're seeing in hospitals.
Lewis, do you think, and this goes to the two of you as well, do you think people know about this enough that they know that so when they're kind of going from, pediatrics to, what was the other one? Adults. Are they aware that they will have to battle these biases and kind of, are they even aware of it?
No, I mean, I don't think anything can really prepare you. And I think the issue is, like, with any NHS, or not just talking about the NHS, but like healthcare systems, they're set up and presented as like, this is how things should work. This is like how things will go in an ideal world. So if you're a pediatric patient, transitioning into adult care, you're going to be told by your hematologist, probably, oh, you just go to A&E and they'll give you morphine straight away and everything will be nice. And like, this is how it's been set up so that you should get the care that you need. But we know in reality, that's not what happens. And sometimes I think healthcare staff aren't quite aware of the reality of what actually happens on the ground in different departments from what they might be used to working in. And this is part of the reason why I got so burnt out and so fed up of working as a GP, because I just felt like I was having to deal with all of these problems that, according to people higher up in leadership positions, weren't problems. Everything's just peach, everything's fine. But it was only fine because I was working my ass off to prevent things from going wrong.
As someone who was, when they were a GP, working their ass off, and still with sickle versus working their ass off, for anyone listening who has sickle cell, is there any advice you could give about maintaining things like work, maintaining activities in your life that are important to you? How can you, from your experience, find a balance that works for you and allows you to live the life you want to live?
Yeah, good question. I think you have to, work in collaboration with your hematology specialist team, because a lot of it is going to be based on medical therapies and engaging fully and knowing what your options are in terms of treating the sickle cell disease to stop it from actually interfering with your life. So I think you have to figure out what is the sort of correct combination of medications or therapy that works for me, that limits the amount of sickle cell crises or pain or the complications I'm having and doesn't cause side effects. And then from that point, I think you just have to figure out what you want to do with your life and, what brings you joy and what makes you happy. And I guess figure out what's realistic. So when I was, when I first started working as a junior doctor, part of the reason that I went on the medication hydroxyurea, which is kind of the standard treatment for preventing sickle cell crisis and reducing the severity, is because the amount of stress that I was under as a new junior doctor was triggering more sickle cell crises than usual. And the amount of sickle cell crises I was having might be nothing compared to what other people were having. But for me, that was so much more, and it was causing such a massive impact on my life because I wasn't able to work at the level that I had to. So that's why I chose to go on hydroxyurea. However, if I knew that I only needed to work at a sort of a less exertive career, then I might not have gone on hydroxyurea. But at that time, I had decided that that's what I wanted to do. So yeah, I feel like I don't want people to limit themselves, but I think you need to make an intentionable choice about your energy exertion, and then whatever that sort of energy requirement is that you need to do the job that you've chosen and continue a career. You then just figure out what you need to make that happen in terms of medications or diet and regular, consistent, moderate exercise.
That's really interesting to hear there, Lewis. And I think I'm realizing now that you genuinely are the perfect guest for this episode, because what kind of harking back to what you said earlier about the healthcare professionals, whether it's at the A&E, not really knowing about the condition, the disease itself, you kind of lose that trust within them as a patient, and it just creates all this doubt. And so, can we just take a little bit of time to not only explain to our listeners, but to any other healthcare providers out there who aren't fully aware of what sickle cell disease is, to explain the disease?
So, I guess in the simplest way, sickle cell is a genetic blood condition that affects the hemoglobin in the red blood cells, and it's caused by a genetic mutation which results in the hemoglobin clumping together and polymerizing when under low oxygen conditions. So this polymerizing of the sickle hemoglobin ends up changing the shape of the red blood cell from round to sickle shaped, and that sickle shape means it's likely to get stuck in small capillary blood vessels and cause ischemia, which is the lack of oxygen to the tissue. And that's probably the sort of main symptom of sickle cell, which is that ischemic pain affecting bones and joints and muscles. And that's what people go and present to the emergency room with most of the time. Obviously, it can cause lots of other complications as well, because it's a multi-system disorder. It's the blood, and blood vessels are all over your body. So you can get strokes, you can get avascular necrosis, it can cause damage to the back of the eyes, it can cause damage to the kidneys, and it's a very severe, serious illness. Obviously, it varies in severity level between different people, but it is something that when people present to the emergency room, they're not just there for no reason. It's very severe pain.
Invisible. It's one of those invisible conditions I'm getting.
Yeah.
Guessing.
There was something really interesting that I read about during the research for this episode, and obviously you're talking about this hemoglobin being mutated in a way that makes it sort of less effective in carrying oxygen. It's altering the shape of the cells to make them less effective as well. But it said, this paper that I read said that normally a healthy red blood cell will live for 120 days, so about a third of a year. But the cells that are sickle-shaped will only live for 10 to 20 days. So it's not even the reduced oxygen carrying capacity that's the only issue. It's then that even with the limited capacity that they have, those cells live 6 to 12 times less long. And so you've got that sort of, your body's being forced to try and create more blood vessels to make, more blood cells to make up for it, which is then using up more of your body's supply anyway. And so it's putting yourself sort of, making you more prone to those high stress situations and those low oxygen situations which feed into a crisis.
Yeah, and that's also a good point, because it ends up causing another common symptom, which is fatigue. So I think we often forget about the anemia, the chronic hemolytic anemia element of sickle cell, which it causes fatigue, and it also causes the jaundice that a lot of people with sickle cell develop, which turns their eyes the yellow color, and is a source of quite a lot of self-consciousness within people with sickle cell disease, unfortunately.
Why did I think that jaundice was just for skin?
Well, the first place you typically see jaundice is in the eyes and the sclera, so the whites of your eyes.
Oh.
And if you're thinking about sickle cell predominantly affecting people with darker skin tones, you're not going to be able to see that yellowing as easily.
Oh.
So the eyes is where you're really going to see it. Yeah.
Oh, I just thought...
That's right, isn't it, Lewis?
Yeah, yeah.
And so, obviously, we've touched a little bit on sort of an overview of how the condition works, but how many people does it tend to affect? So how prevalent is this condition?
I think there's around 18 to 20,000 people in the UK living with sickle cell, according to the last figures that I looked at. But it's also the most common genetic condition in the worldwide. So yeah, I don't know exactly how many people it affects, but it's very common.
I think I do because I see it in the notes in front of me. So it's around 7.74 million cases worldwide in 2021, and 34,400 deaths.
And
Wow!
so clearly, like you say, this is an incredibly prevalent condition. I know, considering how little attention it gets in media and how little discussion and understanding there is about it in society, it's hugely prevalent. And you look at, I think this is always the example people use to say, but this condition's really rare, so why do we know so much about it? But if you look at motor neuron disease, for example, a condition that is incredibly rare, and yet because of a few sort of famous public cases, we talk about it a lot, and people have a relatively good understanding as a society about what the condition is, and yet sickle cell, which is far more prevalent, just does not get that same attention at all.
Yeah, I think from looking at the statistics as well, there's approximately 300,000 people a year born with sickle cell. So you mentioned about the misconceptions regarding how somebody would have sickle cell, and people not knowing that it's genetic. In the UK, we do screen all babies for sickle cell and the like, don't we?
Yeah, so it's been part of the national newborn screening program since the early 90s. So if you're born in the UK, then there's a high chance you'll be diagnosed and it will be picked up from birth. However, we've still got people emigrating to the UK that haven't been diagnosed with it, and they're being picked up later.
And so, thinking about the people that are born in the UK with this condition, one thing that maybe you can clarify a little bit for me, it says that typically symptoms tend to begin in the second half of the first year of life, so they don't tend to start before 6 months old. Can you kind of give us a bit more of a clue about why that might be? And I think maybe that would lead us nicely onto these kind of discussions of hydroxyurea that you mentioned earlier on as a treatment.
Yeah. So babies in the womb have a special type of hemoglobin in their blood called fetal hemoglobin, and that is very good at carrying oxygen and allows them to get oxygen from the mother's blood. So after babies are born, they persist with fetal hemoglobin for up to around 6 to 9 months of age. But then if they have sickle cell, the fetal hemoglobin stops being produced and the adult hemoglobin is produced. And in the case of sickle cell, that is the sickle hemoglobin, which then ends up causing the symptoms.
Sorry, Lewis, you said when they've got sickle cell, are you talking about the mother or the baby fetus?
The baby. So when the baby born with sickle cell, they'll have fetal hemoglobin in their blood until the age of around 6 months, 9 months. And then they will start to produce the sickle hemoglobin, which will cause the complications.
Right.
And am I right in saying hydroxyurea, that drug that you spoke about taking to help you kind of deal with the workload of being a junior doctor, that increases that production of fetal hemoglobin in older people with sickle cell? So people, when they stop producing it naturally themselves, it helps to produce this to help their oxygen carrying capacity?
Yeah, so hydroxyurea basically triggers a mechanism that switches back on the production of fetal hemoglobin, even after it's gone off as a baby. So it only produces a mild to moderate increase in fetal hemoglobin, but that is often enough to reduce the symptoms of sickle cell and prevent complications.
Can we touch maybe on, obviously that you said is one of the mainstays of treatment. Can you touch on a couple more of the treatments that someone with sickle cell might experience? And also, I think possibly the most recent thing you put on your social media about potentially the issues with one of these particular treatments, the side effects it can cause.
Before we do that, Lewis, I have a question. What is hydroxyurea?
Hydroxyurea. So it's
Okay.
I think it's important just to like briefly explain, because one of the issues with hydroxyurea is that even though it's available as a standard treatment for sickle cell, lots of sickle cell patients don't take it. And this is because hydroxyurea was originally used as a chemotherapy drug. So that was its original use. And that was back in the 1980s. I think it started to be used. They discovered that people with sickle cell who happened to be taking hydroxyurea for leukemias and blood cancers were actually doing a lot better from a sickle cell perspective and having less sickle cell crises and complications. So then they started to investigate the hydroxyurea for use in sickle cell and found that it was increasing the fetal hemoglobin, and that was the mechanism that was, benefiting people with sickle cell. However, because of its legacy use as a chemotherapy drug, and it's just been this constant thing that has followed it around in the minds of people that are afraid of taking medications that cause side effects. They are fearful that it will cause cancer because it's a chemotherapy drug, or that it's toxic. However, it's used at a much lower dose, and has been used for 30 years without any significant evidence of causing cancer in sickle cell patients. So that's what hydroxyurea is.
That's incredibly interesting. I'd never come across that in the reading. That's so interesting that it was like a serendipitous discovery. It was just like a positive side effect of what it was originally being used for.
Yeah. It is cool. The other thing, though, is that it's quite annoying how, sickle cell's been around for all that time, and like the main drug that we have for it was found by accident, rather than, medications being developed so that we have more choices now for people to actually live comfortable lives.
That's a really good point, and that's exactly what was going through my brain as you were describing it earlier. And I was just trying to think of any other medications that was developed from the offset to treat something instead of it just being.
I can tell you
Josh
one.
is going to go for straight away, and I
okay.
think Lewis might be able to guess as well. But are you going for
Viagra.
Viagra?
Right, okay, of course.
That's the classic other one. What was it for?
It was originally designed to be used for heart failure. But they found that it was very, very good at.
But getting back away from Viagra,
Viagra is also used in sickle cell as well. But
is it?
I was just about to say, because I read on the notes something about erections.
About
Priapism.
Priapism, yeah.
Yeah. We can touch back on that later on.
Okay, we'll come back to
I did not
priapism.
expect the episode to go in this direction. So something when we're talking about the lack of research around sickle cell. One, obviously, a condition where the research has been chronically underfunded despite its prevalence, but also one of the harmful side effects of this. There's a study looking at support groups for sickle cell on Facebook, and they found that 45% of the medical posts or medical-related posts on there were accurate, and 55% contained inaccurate information, particularly around hydroxyurea, claiming that it was immunosuppressive, saying that it was ineffective.
On Facebook?
Facebook support groups. And so this is why, and again,
Wow.
obviously, we'll
a
put
good
Lewis's
community.
social media and links to the Sickleverse, how to join, in the show notes of this episode. But having someone like Lewis representing this community and creating this content is so incredibly valuable, to have someone who's going to give you well-researched and well-evidenced information in such a quick and easy way. Because, I mean, what are the longest videos on your social media? 2 minutes, 3 minutes?
Yeah, I try and keep it below 3 minutes maximum. Most are around 1 to 2 minutes.
If you haven't watched them, whether you have sickle cell, know someone that does, or are just interested generally, I think it is well worth having a look and finding out more. Can I hark back? I know we've kind of jumped around a little bit, but we spoke about sickle cell disease being one of the things that's part of the national screening process. Both in babies or in adults, how is sickle cell actually diagnosed?
So sickle cell is diagnosed by blood tests. So the mainstay is electrophoresis, which basically separates out the hemoglobin types that are in the blood, so that we can see whether there's sickle hemoglobin present and the percentage, and that usually points to a diagnosis. I think there's other genetic testing done, but I'm not sure on the details of that. But sickle cell has different variations, so there's different types based on the genes. So there's the hemoglobin SS, which is where you inherit 2 copies of the gene for sickle hemoglobin, one from each parent. And then there's other common variations. So I have hemoglobin SC. So I've got one sickle hemoglobin gene and one hemoglobin C gene. So that gives me a slightly milder phenotype. So I have slightly milder symptoms. And this is like a generalization between the SS and SC subtypes. SS always tends to be more severe than SC, but sometimes you'll meet people who have SS who have no symptoms. Sometimes you'll meet people with SC who have like every complication going. So there's still a lot more research to do to figure out lots of other factors which affect how people experience the disease.
So I suppose one of the questions that listeners might have is, if their parent has sickle cell disease, does that necessarily mean that they're guaranteed to have sickle cell?
No. So the way that it's inherited is kind of I'm a bit of a visual person, so I kind of need to describe it visually. But you can basically only get sickle cell if you inherit 2 copies of the gene. So if your parent has sickle cell, they themselves have 2 copies. If your other parent doesn't have sickle cell, then you can only get one of the sickle cell genes. So you'll therefore be a carrier. So you'll have one sickle cell gene and one normal gene. However, in order to have sickle cell, you have to have 2 copies of the gene. So basically, to think of it in another way, if you have sickle cell and you have a child with someone who has sickle cell, then that child is 100% going to have sickle cell. If you have a child with someone who doesn't have sickle cell, then there's a 50% chance that that child will be a carrier of the sickle cell. No, there's a 100% chance that they'll be a carrier of the sickle cell. If you have 2 carriers of the sickle cell gene, this is the main relationship that we want to target, because 2 carriers of the sickle cell gene wouldn't necessarily be aware that they're carriers until they're tested. So people often end up having children and they get diagnosed with sickle cell and they have no idea. So we really want people to get tested to see whether they're carriers or not. Because when you're a carrier and you have a child with another carrier, there's a 50% chance that they'll have sickle cell.
How can one get tested? Like, can you just request a test from a GP?
You can, and yeah, ideally you should just be able to do that. But there are going to be some GPs that might not be able to do the test, in which case you would go to your hematology team. So there are community hematology teams around the country that can do genotype testing for you, but it should be available from every GP as well. It's just that sometimes the indication for ordering the test can be a bit tricky. However, if you say to your GP that it's for family planning purposes, they should be able to justify ordering it. They should order it anyway, but yeah.
That would make it easier.
Yeah, really useful advice for people who might be in that situation to phrase it from that point of view to get a higher chance of making sure they get the appropriate testing that they need.
Yeah, and my question there then was a follow-up question, if you will. I've heard about genetic counselling. So would that only take effect once you confirm that you're a carrier, or what is the process of that? Because I think that's an interesting sort of part of family planning for people that might have sickle cell or sickle cell trait.
Yeah, I think once there's confirmation that you're at risk of having a pregnancy with sickle cell, then you can arrange to see a genetic counsellor, because it's obviously quite complicated, as I've just been trying to explain the risks of having a baby with sickle cell. So talking through all of that in a nice, relaxed, controlled setting and being able to process it is one of the benefits of talking to a genetic counsellor, and being able to sort of, I guess, express all those thoughts and feelings and think about what life might look like, and basically make a decision that you feel happy with and comfortable with. So that counselling can be done whilst you're thinking about a pregnancy, or it can be done whilst you're already pregnant. So genetic counsellors are available for couples to speak to, and they can be really helpful for helping think through the decisions that they're making and consider different options.
Credit where it's due as well. You said the genetics that you were trying to explain, I think you did an excellent job, considering it's a podcast medium and you couldn't show people. Obviously, we could see your hands moving to demonstrate it, but I think you did a very good job, all things considered. We can put some diagrams on our social media as well for anyone who is also a visual learner, just so they can get a bit more of a picture of what the risks might be with different phenotypes. And so we've touched a little bit then on how obviously appropriate analgesia is a major part of managing sickle cell crises. We spoke about how hydroxyurea might be an option that people tend to use in that sort of longer term management. But what other things can people with sickle cell do to manage their condition?
I just wanted to mention the other treatments as well. So there's blood transfusions that are a common therapy for sickle cell. So basically having an exchange transfusion where you receive normal donated blood at the same time that your sickle cell blood is taken away, so that you reduce the amount of sickle hemoglobin in the blood, and that can help prevent things like strokes and reduce the chances of pain complications. So that's the other main treatment method. I think that there are a few other treatments as well, but they're less well established. So hydroxyurea and blood transfusions are the main ones. In terms of what can you do to self-manage for yourself, a lot of it comes down to trigger avoidance. So the main triggers for sickle cell are dehydration, So that tends to make the blood more sticky, and the blood cells are more likely to get stuck in tiny blood vessels when you're dehydrated. So drinking a lot of water, at least 3 liters a day, is recommended. Particularly when you're in stressful situations or going to be exerting yourself. The other thing you can do is exercise regularly, because that will help. Having a moderate level of cardiovascular fitness will help prevent crises and help improve the oxygenation of your blood and your cells. But you have to be very careful not to overdo it, because exercise can also be a trigger for crises. So if you're over exercising, which is what happened to me quite often, whenever I pushed too far, I would trigger a crisis, because the low oxygen level is what's going to turn the cells sickle shaped and cause a traffic jam in the blood vessels. And then there's lots of dietary things you can do as well. I was recently talking about antioxidants and how helpful they are to sort of be like a protective layer against all the oxidative stress that sickle cell causes and all the inflammation in the blood. So eating things like berries and vitamin C and lots of other like herbs, moringa. So yeah, there are a few different dietary tips that you can utilize, but in general, you want to be making sure that you have like a really healthy diet anyway, with sickle cell. Infections are another trigger, so making sure that you get your vaccinations to help with your immunity from serious infections. Sickle cell does affect the spleen, which is an organ that's involved in the immune system. So because of the way that it damages small blood vessels, the spleen is an organ that unfortunately has a lot of small blood vessels, and those can end up getting blocked. And once the lack of blood flow starts affecting the spleen, it shrinks and shrivels up and basically becomes dysfunctional. So it can't play its role in the immune system defense. This is why we tend to take regular penicillin, which is an antibiotic that helps to prevent serious infections like septicemia, meningitis, pneumonia. So usually children, because they have a weaker immune system, are put on penicillin from birth up to at least the age of 5. After the age of 5, the evidence is a little less clear on whether it's worth continuing penicillin or not, and it's left up to the individual to decide.
Wow.
It's currently Ramadan for those who
At the time of recording.
At the time of recording, and you mentioning all of those kind of barriers just got me thinking about that. It must be so difficult to, when you're facing that fatigue. Not only are you fasting,
What if you were
an
someone
athlete
who's Muslim with sickle cell and you're trying to remain hydrated appropriately?
Yeah, and if you're an athlete or you want to maintain your fitness as well, it must be so difficult.
One thing that I wanted to talk about briefly, Lewis, obviously you were saying about the spleen and the small blood vessels and that make it quite vulnerable to damage. One thing that I found that I'd never really considered before, depending on the cohort of people studied, between 12% and 66%, which I know is a wide range, but it obviously is cohort dependent, of people with sickle cell have hearing loss, because the labyrinthine artery, which feeds the cochlea, one of the parts of your ear that helps you to hear, basically doesn't have much collateral circulation, so there's not many other blood vessels that can reroute around it if that gets blocked.
Yeah, so collateral being like backup.
Exactly.
Yeah.
And so if there's no backup circulation, it's very vulnerable apparently during these occlusive crises where the blood vessels get blocked. So symptoms, obviously before you said it's a systemic condition, but I think maybe if people do have any knowledge of sickle cell, they'll have seen kind of these conventional ideas of severe muscle pain, for example, but actually just understanding just how broad this condition is in its effect. I hope that people listening are starting to see just how systemic this condition really is.
Yeah, it's a really good point, because sickle cell is often deemed as just an acute crisis pain condition that you just present to the emergency department with, and often the other long-term complications like hearing loss are kind of ignored, and the unfortunate thing is that's one of the reasons that people don't choose to go on medications like hydroxyurea to improve their disease. And I see a lot of people who are just taking painkillers whenever they have pain, and there's no sort of protection against the silent organ damage that can occur in sickle cell. So yeah, it's a really good point to acknowledge that, there's so many different complications that can be caused, strokes, you've got sickle cell retinopathy, the blood vessels at the back of the eye being affected. Obviously the spleen gets taken out. It can take out the bones. People can get avascular necrosis in the hips and in the shoulder joints, and that's again because there's not much collateral blood supply in those areas, and the joint ends up crumbling, and they have to have joint replacements. And these people are like probably in their 20s, 30s, very young people working. So yeah, I don't think everyone always is aware of that. With sickle cell.
And I mean, with obviously you talk about people maybe not wanting to engage with things like hydroxyurea and not engage with certain treatments, and really, can you blame people when you consider sort of there's various papers about barriers to accessing care in sickle cell, and some of the opinions that are pervasive among healthcare professionals, you can understand why people maybe become disengaged from healthcare. So there was one study of A&E nurses that found that nearly 56% of them felt that sickle cell disease patients in A&E were drug seeking, and they described the people as opioid addicts, and they also had a longer wait time for analgesia. They had over double the length wait time compared to what the national guidelines are, so they were waiting for 70 to 75 minutes on average compared to 30 minutes for people in any other sort of pain crisis. And if you're being so consistently undertreated and mistreated, then having trust and faith in that system, it would be really hard to maintain.
So they were just waiting to see if they would just wait for the actual drugs, or just...
No, I think effectively they were just saying, well, this person, if they're not drug seeking, then they'll wait. Yeah, I think it's their sort of heartless attitude towards it.
56%, that's ridiculous.
Yeah.
I think one of the things in terms of emergency care in the UK as well is that the drugs that we need to use are controlled drugs. So for nurses in particular, there's a lot of hoops to jump through for them to even administer the drugs as well. They have to get it co-signed. They have to log everything down that they're using because, as I said, controlled drugs. So there's that delay as well from it.
But do you think that there's the delay from actually providing the drugs, doing the bureaucratic side of it, but do you think there's an element of the fact that effectively a can't be asked element because there's so much paperwork around it? Do you think that they're just taking a step back from it?
I think that I've been on the receiving end of this. There's no sense of urgency. If someone came in a heart attack, it would be all hands on deck. If someone came in having a stroke, it's rapid, immediate action. Whereas if someone comes in with a sickle cell crisis, if there's this, unconscious perception or even like conscious perception, they're a drug addict. It's, they're bottom of the priority list, and it's not treated like a medical emergency in the way that it should be. So these, recommendations, 30 minutes, strong IV analgesia in 30 minutes, that just goes out of the window because people have it in their head. This is a drug addict, therefore they don't deserve, to be treated with respect and be treated like an emergency because they look fine as well.
And I guess the terrifying part of that is that obviously we've spoken about the fact that people can go into acute kidney failure as a result of a sickle cell crisis. People can have strokes, people can have seizures. Does it have to take one of these symptoms? Does it have to take something life-threatening to be taken seriously? I think obviously if someone came in with a stroke, I'm sure very quickly people would get their act together because it's something that maybe they know more about and they recognise. But why should the correct treatment be missed so many times along the journey, and only when it's something that's going to permanently affect that person's quality of life do they actually get the attention that they deserve?
I've got a question. So the theme about clinicians, nurses not knowing enough about the disease has come up a few times throughout this podcast. During your medical training, how much of that focused on sickle cell? You, I guess.
I'm happy to answer first, Lewis, and then you can have the final word on it if you'd like.
Yeah, go ahead.
I think I was very lucky in that I was in the centre of London sort of training. It was actually sickle cell, I think, was the first week of medical school for me. So, yeah, we talked about it. We had people with sickle cell come in and talk about, like you're doing now, talking about experiences and what have you. But it was 1 week, that's it, no more. The next time I'd even seen a patient with sickle cell, I was in my F2 year, so 2 years, second year of being a doctor.
So is that 6 years later?
Yeah, over 6 years later, yeah.
Yeah.
Yeah, I would say that's really good. What you had, I had barely, it wasn't even a full lecture, and it was just the sort of theoretical side of it. Sickle cell mixed in with lots of other blood conditions. So I don't think I saw anyone with sickle cell until I was actually working as a doctor. We get very little training on it, and that is part of the reason why staff don't understand how severe it is, and why all these sort of unconscious biases can come into it and affect how sickle cell patients are treated, unfortunately.
And I guess that kind of perfectly leads us on as we sort of head towards the end of the episode into what you're doing with Sickleverse. And I know we touched on it briefly at the beginning of the episode, but for people to really start learning about how this should be appropriately managed, to have a better understanding of what it is, to avoid some of the myths that people fall into, do you want to talk us through sort of the different things that you're providing through Sickleverse?
Sure. So at the moment, what I'm working on is the Sickleverse Live Masterclasses, which is where I'm going to be presenting a different topic each week, which is related to a long-term complication of sickle cell. So we're going to be talking about things like fatigue and the chronic anemia, and sort of giving helpful ways to manage that and just understand it. And then things like avascular necrosis and retinopathy and chronic pain. So those are going to be sessions to get people to just get them armed with knowledge, because one of the key, I think, areas that can make a difference is when people are aware of the consequences of not taking medications. And there are so many people that I meet since I've been on social media that don't even know what hydroxyurea is and don't know that it's beneficial. So I'm just trying to spread awareness using the sort of skills and experience that I have to be able to talk about medical subjects, but also give people that trust that I'm not going to recommend anything for them that I, as a sickle cell patient, wouldn't, agree with myself. So yeah, I'm just trying to really help people feel less scared and less overwhelmed by all of this sort of technical medical detail. Hopefully in the future, I've got a lot of plans for other services that I can carry out. One of them is going to be like an advocacy service digitally. So I'm sort of thinking about using AI to help people record their consultations so that they can then get a summary, and I can go through it with them and actually help them understand what's gone on. And I think just having that advocate in the room with you, even if there's no one in the room, if when doctors are aware that they are being, observed, they tend to be a bit better. So that's one of the ideas. But at the moment, I'm working on the Sickleverse Live Masterclasses, which is really just a way for me to share information so that people feel like they really understand sickle cell. And in the future, I'll be doing work with healthcare professionals as well, because I've got a lot of followers that are healthcare professionals that want to, improve their education as well.
That is, I really, really like that idea. I mean, all of those ideas are brilliant, but the idea of helping people digest their consultations, go through that with them, that is brilliant.
I feel like we need to clone you like several hundred times
for every submission.
There's going to be so many people. How are you going to do that for everyone? That's really, really incredible.
It's a brilliant idea to try and find that balance where you're holding people accountable, but it's something that you can manage. Because otherwise, I feel like you sound like you already have a lot on your plate. So to try and go with people would obviously not be feasible, but what a phenomenal idea.
Joe and I went on a walk this morning, and we were kind of talking about the conceptions of all these. So the charity that I work for, literally, it was called Twining Enterprise until we merged with another charity, but it was founded on the grounds of the Twinings Tea Company. And I was just thinking about that because it came from like such a simple idea of helping people with all these barriers into a full-on charity, and we've been funded by the DWP, and it's become this massive thing. And this kind of your idea, it gave me this sense that it could be this massive thing that can help so many people. So I really do hope that you get all the support and funding and whatever it takes to make that happen, because it sounds fantastic.
Yeah. And you couldn't be a better person to do it, really.
Yeah.
And as everyone listening will hopefully have heard, such a fantastic way of explaining things, making things so digestible. Like, really, we're incredibly grateful for you coming on the podcast, and we hope that listeners at home will go and check out Sickleverse and everything Lewis is working on.
Yeah, please do.
Thank you so much.
Oh no, thank you so much. It's been great having you on. I think that brings us towards the end of our episode. All that's left for us to do is do our book review, I believe. Is it, Joe?
Yep, and we will cut away now to a nice transition of our review this week. So this week we are talking about a book called The Meaning of Pain by Nick Potter. And this book starts off like a lot of different pain books do. It'll start off talking about sort of the biological mechanisms of pain, talks a little bit about the biopsychosocial model. The issue with this book is that it then goes into a lot of stuff that's really not very well researched and making some very big claims about basically how the author is just fixing people's pain left, right and centre, and how he can spot that people have been abused or things just by the way that they walk. Just some crazy ass claims, basically. And I think at the beginning it can maybe bait you into thinking that it's a really nice, well-researched book, and there are bits of it that are well-researched, but I think there's a lot of claims in there that go far beyond the capabilities and remit of the author. So just one of the books out there for you to be a little bit more careful about. And so I think somewhere around a 3 out of 10, probably because of that reason. So just be careful when you're reading these books about pain. We've mentioned this before. There's books out there like How to Get Rid of Your Pain by Stopping Eating Wheat. There's some books out there that don't necessarily always give you the best quality information. And so it's important to keep your eyes peeled and to keep on listening to this podcast so you can hear stuff that's well evidenced. And on that note, let's finish the podcast.
So it's goodbye from me.
Oh, yeah, goodbye from me too.
I guess it's also goodbye from me.
Goodbye from me as well.
And we'll see you in a fortnight's time.